Hi, my name is Jana Leto, and I'm a Policy and Regulatory Affairs Manager with the California Telehealth Resource Center. I'm excited to share the second session in the three-part Spark series going over the digital health updates in the calendar year 2026 Medicare physician fee schedule. This time, we're going to be talking about updates related to Medicare telehealth. Before we get started, CTRC does not provide legal advice. All materials are strictly for informational and educational purposes only, and we strongly encourage you to connect with your own billing and compliance teams to assess how the updates covered in this session may impact your organization. Before diving into today's Spark session, I wanted to level set how we're going to talk through all the digital health updates in the final rule. When we talk about payment for digital health, things can get confusing fast. So we're going to use the same simple framework in all three sessions to make sure the information is clear and consistent. There are three questions we need to answer before diving into coverage coding and reimbursement. And the first is the modality. So in this session, we'll be talking about Medicare telehealth. Our provider types are going to be focused on physician fee schedule paid providers, and then FQHCs and RHCs, which have their own unique billing pathways. And our payer is going to be Medicare. And I'll continue to reinforce that because telehealth can be different under different payment programs. With those basics anchored, we'll walk through what CMS finalized for Medicare telehealth in its 2026 physician fee schedule final rule. So as I mentioned, this is the second in a series going over the digital health updates on the Medicare physician fee schedule final rule. In this session, we'll be discussing updates related to Medicare telehealth. Our last session was related to remote physiological management and remote therapeutic management. I encourage you to visit the CTRC and YouTube to catch that recording and learn more about those updates. So the physician fee schedule final rule, which we'll be going over today, was issued on Halloween and will become effective on January 1, 2026. So let's dive into the updates. Before going into what CMS finalized for Medicare telehealth, I wanted to share that in November, Congress extended the Medicare telehealth flexibilities that previously expired on September 30th, 2025. So this means that these flexibilities now expire on January 30th, 2026. This change is retroactive, meaning any telehealth visits from October 1, 2025 onward that weren't covered under permanent telehealth rules are now covered under extended flexibilities. And you can see those flexibilities that have been extended through January 30th, 2026 in the table here. So as you can see, there are no geographic restrictions for Medicare non-behavioral telehealth visits. The home can continue serving as the originating site. PTs, OTs, and speech language pathologists, audiologists continue to be eligible telehealth providers. FQHCs and RHCs can continue to serve as distance site providers. The in-person visit requirements have been delayed. Audio-only non-behavioral telehealth visits continue to be available. Then for recertification of eligibility for hospice care, telehealth continues to meet that face-to-face encounter requirement. And then the acute hospital care at home initiative was extended. And as I mentioned, the flexibilities expire January 30th, 2026. There are statutory exceptions for these restrictions, even after the pandemic era flexibilities expire. So I wanted to level set a little bit on what restrictions are. So under Medicare's original telehealth rules, there was a geographic requirement. So the patient had to be located in a rural health professionals shortage area, known as a HIPSA, or outside a metropolitan statistical area for telehealth services to be covered. There was also originating site requirements. So this is the physical location where the patient is during the telehealth visit. And traditionally, Medicare only allowed certain sites, so that can be like the physician office, clinics, or hospitals, to qualify as a qualifying originating site. The patient's home was generally excluded, except for certain exceptions. And the originating site also had to meet that geographic requirement. So as you can see here, these are the exceptions. So for monthly and stage renal disease-related visits, geographic restrictions for telehealth do not apply when furnished at certain originating sites, which include the home of the individual. The originating site requirement is also waived for telehealth use in diagnosis, evaluating, and treatment of acute stroke. And the geographic restrictions are waived for telehealth furnished for individuals with substance use disorder or co-occurring mental health disorders at approved originating sites, which also include the home. There were also certain flexibilities that were made permanent related to behavioral telehealth, and you can see that here, where home is permitted under certain conditions. So that means that their in-person visit has to be met, but that in-person visit, as I mentioned, that requirement is delayed until January 30th, 2026. There are also no geographic restrictions for originating site. You can continue to receive behavioral mental health telehealth services via audio-only communication platforms, marriage and family therapists and mental health counselors, as well as FQHCs and RHCs can serve as business site providers for behavioral mental health telehealth services. So in the calendar year 2026 Medicare physician fee schedule, CMS finalized payment of $31.85 for the telehealth originating site fee. They also added 4 new services to the Medicare Telehealth services list, and you can see that here. They relate to group behavioral counseling for obesity, multifamily group psychotherapy, infectious disease add-on for inpatient visits, and auditory integrated sound processor visits. CMS will also permanently allow physicians to be immediately available via real-time audio-video technology, excluding audio only, and these are for services incident to a physician's professional services, except for procedures with global surgery indicators. Then teaching physicians may now have a virtual presence in all teaching settings, only when the service itself is furnished virtually, so it's essentially a 3-way virtual visit, where the teaching physician, the resident, and the patient are in different locations. And then CMS permanently removed frequency limitations for subsequent inpatient visits, subsequent nursing facility visits, and critical care consultation. In terms of FQHCs, RHCs, so on the left, you can see what CMS finalized. So these services furnished via telecommunications technology. These are standard FQHC and RHC medical visits that happen to be delivered using video or audio. Even though they look similar to telehealth, these are distinct from Medicare telehealth services and fall outside of the Medicare telehealth statute. And in the calendar year 2026 physician fee schedule final rule, CMS extended coverage for these medical visits furnished via telecommunications technology through December 31, 2026. On the right-hand side, you can see telehealth services furnished via telehealth. And these are the formal Medicare telehealth services defined in the statute under the Social Security Act. They come with specific rules, so there are geographic requirements, originating site limits, and other statutory conditions. During COVID and afterward, Congress temporarily allowed FQHCs and RHCs to service distant sites and bill for these services through G2025 code. Congress recently extended those flexibilities again, but only through January 30th, 2026. So after that date, the statutory Medicare Telehealth Authority for FQHCs and RHCs to service distant site providers expires unless Congress takes additional action. And so, as you can see, what's the difference? Like services furnished via telecommunications technology look very similar to Medicare telehealth. And to patients and providers, those 2 categories feel almost identical, especially since they both involve real-time video or audio interaction. The difference in itself is not clinical, it's actually legal. So a good example is virtual check-in. So virtual check-ins use real-time communication technology. They feel like a really quick telehealth visit, but they're not considered Medicare telehealth services. And since they sit outside the telehealth statute, virtual check-ins aren't subject to the telehealth restrictions, and CMS is using its authority to pay for them separately. So CMS is using the same distinction for FQHC and RHC services furnished via telecommunications technology. In terms of mental health, telehealth for FQHCs and RHCs, that in-person mental health visit required within 6 months prior to a telehealth mental health service, and then that annual in-person visit would have been required starting October 1, 2025. But because of congressional action, that in-person visit requirement for behavioral mental health has been delayed until January 30th, 2026. And then in terms of the practitioner address, so there were commenters in the final rule that were concerned that CMS didn't propose to extend the flexibility allowing telehealth practitioners to use their enrolled practice location instead of their home address when they billed for telehealth services provided from when they were in their own home. CMS clarified that they didn't need to do any rulemaking extension and pointed to an FAQ that explained how to suppress the street address details for safety and privacy while practitioners could use their enrolled practice while continuing to use their enrolled practice location. And then CMS also reiterated that state law governs licensure for distance site telehealth practitioners, and then indicated that any future updates related to this is going to be issued via sub-regulatory guidance and not future rulemaking. So that brings us to the close of our Medicare telehealth updates. Our next Spark session will be related to digital health updates related to artificial intelligence. So please follow us on the CTRC website and socials to keep an eye out for that Spark session and to learn more about those changes. If you have any questions about today's session or have any feedback, please connect with us using the QR code here. And again, please stay tuned for that last session in the Spark series on AI-related updates. Thanks again for joining us.